Greetings, everybody. Welcome to part 29 of our internal medicine review questions. We got another 10 questions coming your way. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you very much who have already donated. All right, let's go ahead and look at question 1. Question 1. A 62-year-old man presents to the clinic complaining of neck and hip pain and stiffness for the past 2 months. He says, I feel fine otherwise. I just feel sluggish and stiff in the morning. It's better as the day goes on. He denies headache, scalp tenderness, and changes in vision. He has no other medical issues and takes a multivitamin and low-dose aspirin every day. Vitals are within normal limits, but he's lost 10 pounds since his last visit for his annual physical 6 months ago. On physical exam, you note normal passive range of motion, mild pain, an active motion at the neck, shoulders, and hips. CBC, TSH, and creatine kinase are as shown. Based on the most likely diagnosis, which of the following is the best next step in the management of this patient? Let's look at the labs first. Okay, so here's your labs. You got your CBC, your creatine kinase, TSH, and sed rate. Okay, let's look at our answer choices. A, low-dose prednisone. B, high-dose prednisone. C, indomethacin. D, temporal artery biopsy. E, MRI of the shoulder. Or F, HLA-B27 serotyping. Okay, let's look at our labs again here if you want. I'll let you pause, and we're going to go to our answer. So it's low-dose prednisone. What does this man have? Polymyalgia rheumatica. Okay, so we look at his pain. He wakes up with pain, and it is worse in the morning. When you hear a patient who's got musculoskeletal pain that's worse in the morning, you need to be thinking of inflammatory issues. Now, is this inflammatory? Yes. Polymyalgia rheumatica is an inflammatory disorder. That's why when we look at our labs here, you see the elevated sed rate. However, we have a normal creatine kinase. So that elevated sed rate should tell you that you've got some kind of an inflammatory issue going on here. Okay, and so with any kind of inflammatory musculoskeletal pain, it's going to be worse in the morning and it's going to improve as the day goes on. Now, polymyalgia rheumatica is not weakness. Okay, so they don't have weakness like you would see in polymyositis and dermatomyositis, in myopathies like those induced by glucocorticoids, statins. So this is pain, okay? It's all pain, no weakness. And that's what we see here. Now, another thing with polymyalgia rheumatica, it happens in a very specific patient population. And what patient population is that? Older people. So you're not going to get a 40-year-old coming in with polymyalgia rheumatica. If this were a 40-year-old coming in with musculoskeletal pain, particularly in the morning, I might be getting a rheumatoid factor. If this were a patient with vague pain throughout the day, maybe a 42-year-old woman, I might get thyroid hormones, maybe check for trigger points, looking maybe for fibromyalgia. Of course, you're going to be getting, CBC, BMP, sed rate, because we want to exclude inflammatory processes. But it's very important that you know your patient population. That's going to give you a very big hint. Now, when you've got a patient who you suspect polymyalgia rheumatica, you get your labs, it comes back, you have a presumptive diagnosis. But even before that, what you want to do is exclude what? Temporal arteritis. Temporal arteritis can come with polymyalgia rheumatica. That doesn't mean everyone with PMR has it, but temporal arteritis generally occurs in the setting of polymyalgia rheumatica. Temporal arteritis, also known as giant cell arteritis. So we look for a few things when we want to exclude temporal arteritis. You always need to do it in a patient when you diagnose polymyalgia rheumatica because it's going to alter the treatment. So we look for things like headache, scalp tenderness, jaw claudication, vision loss. And we see here he doesn't have any of that. He doesn't have headache. He doesn't have scalp tenderness. He doesn't have changes in vision. And so what that's telling you is that he does not have temporal arteritis. Now, if they said he's got a very prominent vessel in his forehead, on his temple, if they said he's got changes in vision, his vision has been blurry, he lays on a pillow and it hurts his scalp, that looks like temporal arteritis. And what do you do then? You get a biopsy of the temporal artery and you put them on what? Prednisone. What kind of prednisone? High-dose prednisone. If it's just PMR, you can go with low-dose prednisone. Okay, so B would be the right answer if he presented the exact same way and said he had scalp tenderness, or said he had changes in vision, or said he had a new headache. Okay, indomethacin. Less effective than steroids. You got to give steroids. Okay. So you got to give steroids in PMR, but indomethacin can be used for breakthrough pain, but it is not the first-line agent. Temporal artery biopsy, that would be our next step if we suspected PMR, if we expected temporal arteritis. MRI of the shoulder. No reason. There's no reason to suspect structural injury. That would be something we would do maybe if he just had pain in the shoulder, normal sed rate, normal labs, and things were limited to the shoulder. Okay, think of maybe like a rotator cuff injury. HLA-B27 serotyping. It's going to be negative here because this is not a seronegative spondyloarthropathy. This is not ankylosing spondylitis. It's not psoriatic arthritis. It's nothing like that. Okay, so the answer is A. Here's about polymyalgia rheumatica. Note, happens in older people. It says more than 50, but usually it's quite a bit older than that. Bilateral pain and morning stiffness, and involving typically the larger muscles, more proximal muscles. It can be described as joint pain, but usually these patients will tell you that it's just kind of a generalized pain. Decreased active range of motion, limited by pain. Okay, normal strength. I need to stress that here. Normal strength. If you're looking at a patient who has weakness and pain, then maybe you're looking at something like a polymyositis. All right. Elevated sed rate. This is an inflammatory disorder. Therefore, they may also have normocytic anemia, which would be the anemia of chronic disease. The management for polymyalgia rheumatica is low dose oral glucocorticoids. If the patient had temporal arteritis, then you would go with high-dose glucocorticoids. Complication, we talked about it. Giant cell arteritis, temporal arteritis, same thing. Okay, same thing. All right, question 2. A 52-year-old woman presents to the clinic complaining of constipation, nausea, weight loss, and fatigue for the past 3 months. She tells you, I don't know what's wrong. I'm sleeping 9 hours every night and I feel sluggish throughout the day. At first I thought it was menopause, but now I don't know. Her menstrual periods were regular throughout her life, but now her cycles are irregular and separated by at least a couple months. She's otherwise healthy and takes no medication. She doesn't drink alcohol, smoke, or use recreational drugs. Vitals are within normal limits. BMI is 22. On physical exam, the patient appears pale. Neck is supple and without masses or goiter. Abdomen is soft, non-tender, non-distended. There's prolonged relaxation time of the ankle reflexes. Labs are as shown. Which of the following is the best next step in the management of this patient? Let's look at the labs. Okay, here's your labs. We got quite a few of them. Okay, let's take a look at our answer choices. A, reverse T3 level. B, serum T3 level. C, antithyroid peroxidase titers. D, ACTH level and cosentropin stimulation test. Or E, thyroglobulin level. Okay, so let's go ahead and look at our labs again. And let's take a look at our answer. So it's D, ACTH level and cosentropin stimulation test. All right, so let's look at this patient. She's got constipation, nausea, weight loss, and fatigue. Okay, so we don't really know. Those are kind of non-specific. You might think constipation and fatigue, that sounds like hypothyroidism. Nausea and weight loss, it's kind of non-specific. been going on for a few months. Her menstrual cycles are irregular. So it sounds like there might be some thyroid issues going on. Well, let's take a look at our TFTs. So we see both the TSH and the free T4 are low. Oh boy. So normally when we see hypothyroidism, most of the time, what we see is a high TSH and a low thyroid hormone level. And what that's telling you is that there's something wrong with the thyroid. But here, what this is telling you is that there's something wrong either with the hypothalamus or the pituitary, probably the pituitary. So at that point, when you have a secondary hypothyroidism and it's originating from the brain itself, you need to look for other possible deficiencies in pituitary hormones. And the big one you need to look at is ACTH. All right, ACTH, very, very important. And as a matter of fact, remember, ACTH will stimulate the release of cortisol. And if you look here, and to some degree also aldosterone can play a role, particularly if you're considering this patient who's got the nausea and weight loss, and also if you consider low sodium, high potassium, what's that telling you? Possibly a low aldosterone or low cortisol. And why would you have that? What triggers that? What triggers the adrenals to create these things? ACTH. Okay. Now remember that aldosterone is not directly under the influence of ACTH. It is under the influence of renin. But when you have a lot of ACTH, it can stimulate the production of aldosterone as well. Okay. Now we also see so we also have repeat TFTs, and they confirm this. The prolactin level is normal, so we're not looking at a prolactinoma here. Everything else is looking normal. So this is likely a pituitary issue. And it's affecting her menstrual periods, it's affecting her adrenal function. And so the next thing that we need to do then is to determine whether this is primary or secondary. It is probably secondary because we also have thyroid hormone issues, but we need to check anyway. Okay, we have to check anyway. And the best test to determine whether the thyroid is functioning is to determine whether the adrenals are functioning is ACTH and concentropin stimulation test. If you give ACTH and you get an elevation in your cortisol, that's telling you that your adrenals are working. If you give ACTH and you don't, that's telling you the adrenals aren't working. And so one is secondary, the other is primary. What would we expect here in the setting of her hypothyroidism, which is probably, actually is due to a deficiency in TSH. We expect this is coming from the pituitary. It would be a huge coincidence if she had primary adrenal insufficiency on top of that. So what we would expect is that she has a low ACTH. If we give ACTH, it's going to stimulate the adrenals, and we would get a normal picture. So that is what we are doing with this. Reverse T3 level, why not? So that's what we do if we have a patient who we think may have euthyroid 6 syndrome. What do we know about euthyroid 6 syndrome? Those patients are very, very sick. They're often in the ICU. Maybe they've had a recent heart attack or something like that. Okay, serum T3, very limited role. We typically don't have much use for this, at least on the exam. Anti-TPO titers. If we suspected Hashimoto's, that would be a primary hypothyroidism. We'd have an elevated TSH. ACTH and concentropin stimulation test, obviously that's the right answer. Thyroglobulin level. So that's used in the follow-up of thyroid cancer as well as to investigate for surreptitious thyrotoxicosis. So a patient who's taking thyroid hormone on their own. Remember that thyroglobulin comes from thyroid hormone that is made in your body. It's kind of like the C-peptide for insulin. And so if a patient has hyperthyroidism, they've got a high thyroid hormone suppressed TSH, and you order their thyroglobulin and it comes back normal or low, then what that's telling you is that they're getting exogenous thyroid hormone. That's when thyroglobulin level is useful. It's also useful as a tumor marker. Okay, so the answer is D. All right, so this is a patient Features of hypothyroidism, you're going to get routine labs, get TSH, T4, that was done for you. The low TSH, low T4 suggests that this is from hypothalamic or pituitary origin. This patient also has a hyponatremia and a hyperkalemia. That suggests hypoadrenalism. Okay, so what we need to do then is we need to test for hypoadrenalism. You get your ACTH level, ACTH stimulation test, also called the cosentropin stimulation test. Very, very important that you know that this is a hypopituitarism, not just a hypothyroidism, because that is going to affect how we manage this. If you give levothyroxine to a patient with uncorrected adrenal insufficiency, you can precipitate adrenal crisis. So it is absolutely essential that you know this. Will we give this patient levothyroxine? Yes, but we also need to give it in the setting of all the other things that she is missing, and that is the moral of this story. So here's how we do the workup for suspected adrenal insufficiency. Get a baseline ACTH stimulation test. If there's suboptimal cortisol release, that's telling you that the problem is coming from the adrenals. Get an ACTH level to determine whether it's primary or secondary. ACTH level's high, adrenals aren't working, it's primary adrenal insufficiency. ACTH level's low, there's nothing to stimulate the adrenals, this is secondary adrenal insufficiency, like we saw in this patient. If you have a normal cortisol response, then it's likely something else. Okay, question 3. A 51-year-old man presents to the clinic for follow-up after arteriovenous fistula creation 3 days ago. During the surgery, the surgeon noticed excessive bleeding and oozing despite the application of pressure. The patient says he has never had this before, and he has had multiple surgeries, including an open appendectomy at age 24, a laparoscopic cholecystectomy at age 40, and arthroscopy for medial meniscal tear at age 42. All were uncomplicated. He has a past medical history of uncontrolled diabetes culminating in diabetic nephropathy and stage 4 chronic kidney disease. He is to begin dialysis this week. Medications include basobolus insulin, lisinopril, and metoprolol. Vitals are within normal limits. Physical exam reveals an appropriately healing surgical site on the left forearm and multiple bruises on the legs and arms bilaterally. Pre-op labs are as shown. Great. All right, more labs. Which of the following would be most likely to mitigate this patient's bleeding? Let's look at our labs. Okay, so here you see the CBC, BMP, and COAG studies. Okay, let's look at our answer choices. A, platelet transfusion. B, cryoprecipitate. C, fresh frozen plasma. D, desmopressin. Or E, no further management needed. All right. Let's look at our answer. Desmopressin. All right, what is going on with this patient? What kind of bleeding is this? Clearly he's bleeding. He had excessive bleeding during the surgery, oozing, he's got bruises. What kind of bleeding is this? Okay, so look at your COAG studies. Normal, normal. Platelet count is what? Normal, high, or low? Normal. Well, why is he bleeding? He's got normal PT, normal PTT, normal platelets. Okay, this is the kind of bleeding we would expect if the patient had what? Low platelets. But he's got normal platelets. Why is he having platelet-type bleeding if he's got normal platelet count? Platelet dysfunction. You can have platelets, but they got to work. So why are his platelets not working properly? Because he has uremia. Okay? So all those waste products, those nitrogenous waste products are supposed to get filtered out by the kidney. It's not happening. Not happening. Remember your ammonia cycle. I'm not going to go through the whole thing, but remember you start out with CO2 and NH3, which is ammonia. Carbamoyl phosphate synthase goes to carbamoyl phosphate, enters the urea cycle. What's the end product, the most important product of the urea cycle? It's in the name. Urea. All right, urea. And that can be filtered out by the kidneys. So we turn ammonia basically into urea. It's more complicated than that. You probably remember from step 1, but that's what we do. If you can't do that, then what's going to happen? Ammonia is going to go to arginine, or you'll get a buildup of arginine. And what's going to happen there? It's going to get converted to GSA. Converted to nitric oxide. GSA is guanidinosuccinic acid or something like that. Anyway, NO. So that's going to be what we end up with out of this excess ammonia. Nitric oxide, what's that going to do? It's going to decrease von Willebrand factor secretion. It's going to decrease platelet activation. And it's going to decrease aggregation. Platelets don't work in the presence of all that nitrogen. And so what we need to do then is we need to trigger the release of von Willebrand factor. Why do we want to trigger the release of von Willebrand factor? Because that will help the platelets stick. Remember, GP1B and von Willebrand factor interact. That helps the platelets stick to where they need to be. Helps them adhere. Okay, so it really, it decreases von Willebrand factor secretion, decreases ADP thromboxane A2, which is behind the activation, and it decreases GP2B3A activation, which is behind the decreased aggregation. Remember, GP2B3A binds to fibrinogen, and other platelets will clump to the same fibrinogen, helps you make that nice big complex. Okay, so that makes our answer then pretty easy, because we know that desmopressin increases the secretion of von Willebrand factor, and that's going to help the platelets stick. So this would be our first line. Second line is dialysis, but he's already headed there. What about A, platelet transfusion? Not going to help. Doesn't fix the underlying problem. Cryoprecipitate. This isn't a coagulation problem. Our PT and PTT are normal. What about fresh frozen plasma? Same thing. Not a coagulation problem. And then, of course, there is management that is needed in this patient. So this is platelet dysfunction in CKD. We talked about this, platelet type bleeding. And remember, that's very different from your factor type bleeding. CBC is going to show a normal platelet count. You may have anemia of chronic kidney disease that could be present. Remember, that's due to decreased erythropoietin secretion, so you'd expect to see a normocytic anemia. Coag studies are going to be normal. Desmopressin is the treatment of choice. Question 4. A 59-year-old man presents to the ED complaining of palpitations for the past 3 hours. He's accompanied by his wife. He says that he felt the palpitations come on while he was watching TV. He's had palpitations before, but they've never lasted this long. He denies chest pain, shortness of breath, lightheadedness, and loss of consciousness. He has a past medical history of hypertension for the past 12 years and is controlled with lisinopril hydrochlorothiazide. He's on no other medications. He doesn't drink alcohol, smoke, or use recreational drugs. Vitals show blood pressure 139/83, heart rate 140, respiration 17, temperature 98.6. Physical exam reveals an anxious man, tachycardia, irregular pulse, lungs clear to auscultation, abdomen soft, non-distended. Oh, I put non-distended twice. Non-tender, non-distended. The remainder of the physical exam is normal. EKG is as shown. Which of the following is the best next step in the management of this patient? Let's look at our EKG. Okay, so here you have it. What are we looking at here? Okay, let's go and look at our answer choices. A, amiodarone. B, adenosine. C, metoprolol. D, aspirin and clopidogrel. Or E, digoxin. All right, let's look at our EKG one more time. And we'll go to our answer now. C, metoprolol. Okay, let's look at this EKG. I'm going to zoom in a little bit. Which lead should I zoom in on? I'm going to zoom in on 1. Okay, so what do you see here? So here's your P wave. Here's your QRS. And there's a T wave. Okay, but look at our QRSs. So here, 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 here. Look at the length between these. Is this a regular rhythm? No, not a regular rhythm. And actually, if you go down and look at some of these other leads, you don't really see very discernible P waves. And what does that tell you in the setting of an irregularly irregular rhythm? No P waves. You can see them here. I'm not exactly sure why. But you can't see them down here. You should be able to see them everywhere. Okay, so you're not seeing P waves here. So what that tells you is you got atrial fibrillation. And he also has a tachycardia. I mean, if you look here, there's only 2 lines separating here. And we also saw his tachycardia in the stem of the question, 140. Okay, so tachycardia with AFib, what that's telling you is that you have AFib with rapid ventricular response. And that demands treatment. That's going to be appreciated as palpitations. Now, when you got a patient coming in with palpitations, we're concerned about a coronary syndrome. So you need to get your routine lab, CBC, BMP, get a chest x-ray, get cardiac enzymes, of course, get an EKG. All that stuff needs to be ordered stat. EKG with AFib, it's going to show you no P waves or maybe some, of course, fibrillation, little tiny waves like that. Not your flutter waves like that. Okay, very low amplitude. That's likely AFib. This patient's got risks for it. Okay, he's had hypertension for the last 12 years. We know that's a risk factor. He's tachycardic. So this all points to the same thing. The treatment for AFib with rapid ventricular response is what? Rate control. Rate control. We want to slow that heart down. And what do? Beta blockers or what else? Non-dihydropyridine calcium channel blockers, verapamil, diltiazem. Okay, so these are the drugs that we go to. As we can see here, only one of these fits those categories. So amiodarone, when do we use that? That could be used here. It would be second line, but it's not suitable for chronic use. It's got a lot of adverse effects. Okay, that is rhythm control, but you can use it. Second line, like I said, usually where you're going to see amiodarone is the right answer is if you're looking at wide complex VTAC, monomorphic VTAC, so something like that on your EKG. What about adenosine? When do we use that? PSVT, paroxysmal supraventricular tachycardia. That would be a regular tachycardia with narrow QRS complexes, so something like that. Okay. Aspirin and clopidogrel. So that would be given during a heart attack. He doesn't have that. Digoxin. Rarely used acutely in AFib. This is a drug that's commonly given as an adjunct for heart failure. So that doesn't really play any role here. So it is metoprolol. So here's your algorithm for sustained tachyarrhythmia with a pulse. That's what this guy had. Do your ABCs. This guy was stable. Sinus tachycardia. Was it sinus tachycardia? This guy? No. If it were, treat the underlying cause. That's probably going to be like a panic attack or drug intoxication or something. If it's not sinus tach, then we ask, is the patient hemodynamically unstable? Although that's something you should be asking yourself right away. If the answer is yes, they're hemodynamically unstable after we've done our ABCs and all that, synchronized cardioversion. That's a rule of thumb, okay? We don't use medications to cardiovert a patient who's unstable. We do electrical cardioversion. On the other hand, if you've got a patient who's stable, then we can try to manage it medically. Remember, cardioversion always runs the risk of not working properly, and you can induce ventricular fibrillation, which of course is no bueno. So your next question then, you got a tachyarrhythmia. Are the QRS complexes wide or normal? If they are wide, then, I should have put yes here. Then the question is whether it's a regular rhythm or not. You can see what you can be dealing with down here. I'm not going to go into all that. Here, the QRS complexes were normal in appearance. Okay, you can see these are normal QRS complexes. And so the answer was no. Regular rhythm, the answer was no here. So likely AFib or flutter. You can tell just based on the EKG, it's rate control. All right. If this were a regular rhythm, this would be non-AFib supraventricular tachycardia, and you would start with vagal maneuvers and possibly adenosine. We talked about that. Okay, question 5. A 44-year-old woman presents to the clinic with upper abdominal pain for the past 4 hours. She has a significant past medical history and is on... she has significant past medical history. Okay, I don't know why I wrote that. No significant past medical history. There we go. I should really proofread. I apologize for that. Vitals are within normal limits. Physical exam reveals mild upper abdominal pain. Murphy sign is negative. There's a fluid wave, no jaundice. The remainder of the physical exam is unremarkable. CBC reveals a normocytic anemia, thrombocytopenia, and leukopenia. MCV is 88 femtoliters. Reticulocytes 2.9. CT reveals hepatic vein thrombosis. Flow cytometry is performed and reveals a deficiency of CD55 and CD59, which the following is the most likely cause of this patient's abnormal lab results. A. Splenic sequestration, B. Factor V mutation, C. Prothrombin mutation, D. Monoclonal expansion of immature myelocytes, or E. Inappropriate complement activation. All right. Let's go ahead and look at our answer. Inappropriate complement activation. All right, so you say CD55 and CD59 in a test question. What's the first thing you're thinking of? You better be thinking of paroxysmal nocturnal hemoglobinuria. Okay, so basically what's going on with these patients is that they have an inability to stop complement from lysing their red blood cells. Okay, that's all that's going on here. Let's look at how this happens. So normally, on the surface of the red blood cells, you've got this anchor called GPI, and then on that, expressed on that, is CD55 and CD59. Okay, you don't need to know the details about that, but basically what these things do is they stop complement from killing the red blood cells. So you have all that, great. GPI comes from the PIG-A gene. You got to remember that. Now, if that PIG-A gene is mutated, you don't get that GPI, then the CD55 and CD59, even though you have it, can't work, okay, because it doesn't have anything to attach to. And because of that, complement can attach to the red blood cell, cause hemolysis, and then you will have a hemolytic anemia. Now, that said, it is important to remember that this process doesn't happen all the time. It's more likely to happen in times of low oxygen tension. And so what happens then is you have your normal drop in your oxygen tension when you're sleeping. And so this process accelerates while you're sleeping, and you have the dark colored urine and all that you would associate with hemolytic anemia when they wake up. That's why it's called nocturnal hemoglobinuria. Okay, and so this is a complement issue. And so there you go. Your answer is E. Splenic sequestration. So splenic sequestration is something that, can happen in, various disease processes, but, one of them could be something like, let's say, sickle cell disease or something like that. So there are a number of things that can cause that, but this is not one of them. Mono is another thing. Factor V mutation. That's factor V Leiden. So yeah, that would cause increased thrombosis, but you would not get hemolytic anemia. Prothrombin mutation, same thing. Monoclonal expansion of immature myelocytes, what's that? AML. You wouldn't expect to see CD55 or CD59, but you would have your anemia, thrombocytopenia, and leukopenia. So that does come into play there, but the CD55 and 59 should be the dead giveaway. If you're deficient in that, it's PNH. Okay? Now, what about this whole hepatic vein thrombosis thing going on? That's the explanation of their abdominal signs, but why does this happen? So we don't really know. Hemolysis is, we do know it releases free hemoglobin and maybe some prothrombotic factors, and that increases your risk of thrombosis. Why it happens more in PNH compared to some of the other hemolytic anemias, not really sure, but this one has a strong tendency to cause hepatic vein thrombosis and thus a Budd-Chiari syndrome, and so you're going to have your hepatic signs, you can have an ascites, and so forth. Okay, so this is about PNH. So this is everything we talked about. Flow cytometry is going to be really important because if you have that absence of 55 and 59, you got your diagnosis. Remember your laboratory picture of hemolytic anemia. Of course, this is a Coombs negative hemolytic anemia. There's no antibodies involved here. Treatment, eculizumab. Eculizumab is a monoclonal antibody against C5, and it inhibits the formation of the membrane attack complex. Make sure you're giving iron and folate because these patients are constantly having to make new red blood cells to replace the ones that were hemolyzed. And this is flow cytometry. You may be expected to look at this on your exam and know how to read it. So what you're looking at here is this is more, this is less, this is more, this is less. What this is telling you is you have a lot of cells that are expressing 55 and 59. That's normal. What this is telling you here, again, more or less, sorry, there. What this is telling you is, yes, you've got a normal clone, but you also have this abnormal clone that's not expressing 55 and 59. You could be asked about these graphs here. This does come up. Okay, question 6. A 45-year-old woman presents to the clinic complaining of episodes of left eyelid spasms. This has been going on for the past month. She says, sometimes when I go out in the sun, my eyelid twitches, and yesterday it shut all the way and I had a hard time opening it. Yesterday, it happened when I was driving. Yikes. She says that it's mildly uncomfortable. She has no medical conditions and takes no medications. She doesn't drink alcohol, smoke, or use recreational drugs. Vitals are within normal limits. On examination of her pupillary response, her left eyelid shuts and she opens it with her finger. She says, this is it. This is exactly what happens. Based on the most likely diagnosis, which of the following is the best next step in the management of this patient? A. Carbamazepine. B. Levodopa. C. Anabotulinum toxin A. D. Trihexyphenidyl. Or E. Baclofen. Okay, let's look at our answer. Botox. All right, Anabotulinum toxin A is another name for Botox. What does this patient have? So she's got eyelid twitching. I'm sure you've maybe had this before. It's very common. This is called Blepharospasm, and it's a type of dystonia. Very, very common. However, for some people, it's worse than others. You know, most people, when they're tired, maybe they're a little malnourished, they've got some electrolyte issues, they can get this, okay? You get tired. There are various triggers for it, such as what we saw in this patient. However, when patients come in with blepharospasm, they're having severe spasms to the point where their eye closes and they can't open their eyes. And as you can see in this patient, it is very, very problematic. Many patients, they'll tell you they've got this spasm, but it's not really a big deal. Her eyes are closing while she's driving. So this needs to be addressed. And so because this is blepharospasm, our best next step in management is Botox. First line agent for blepharospasm, Botox, not just for vanity. Carbamazepine, when do we use that? So you can use it in blepharospasm, but you would tend to use that in children if they have blepharospasm. Where do we also use it? In a facial sort of problem. Another facial problem that has triggers, let's say I'm shaving and all of a sudden my jaw hurts really bad and it lasts for a minute or two. What is that? Trigeminal neuralgia. That's the big place where we use carbamazepine. Levodopa, Parkinson's. Now they can get dystonia, but usually it's going to be the extremities rather than the eyes. Trihexyphenidyl. It's an anticholinergic. Can be used, but it's less effective. Baclofen. Not appropriate here, can cause dependency. It's a muscle relaxant. Okay, so there's your answer. All right, question 7. A 27-year-old man is brought to the ED via EMS after a witnessed generalized seizure approximately 1 hour ago. His coworker is in the room and said that the patient was headed to the break room and suddenly collapsed and began convulsing. On review of his chart, you note that his most recent visit was with his neurologist. He has a 10-year history of temporal lobe epilepsy, ADHD, and generalized anxiety disorder. Medications include levetiracetam, methylphenidate, and paroxetine. Vitals are within normal limits. Physical exam reveals a mildly somnolent man, but is otherwise unremarkable. Non-contrast CT of the head is normal. Labs are as shown. Let's look at the labs. So here you are. CBC, BMP, UA, urine drug screen, and a Keppra level. All of these things are what you should be ordering when a patient comes in with a new seizure, or with a seizure. We would also certainly consider a what? What kind of imaging? Non-contrast CT, because we're worried he may have hit his head. That's always a concern when you've got a patient who's had a seizure. Okay. So, A, phosphonatoin, B, furosemide, C, normal saline bolus, D, sodium bicarb infusion, or E, discontinue methylphenidate. Okay, let's look at our labs one more time because there's something very, very important here. Okay. So here's your answer choices. We're going to go to our answer. Normal saline bolus. Okay, let's go back to the labs. What's unusual here? Oh my gosh. Okay, so I ignore this BMP. If you use this BMP and screwed up the answer, I apologize. That BMP is from the last one. So that was from our adrenal insufficiency patient. I apologize for that. Okay, but it doesn't really matter. Look at your urinalysis. Protein, none. Okay, good. Blood, large. Yikes. Red blood cells, 0 to 1. Why large blood, but no red blood cells? What should you be thinking then? What can register as blood on a urinalysis? Hemoglobin, but what else? Myoglobin. Where do we get myoglobin? From muscle breakdown. Why would we have muscle breakdown in a patient with epilepsy who just had a seizure? Rhabdomyolysis. Rhabdomyolysis. And what do we need to do when a patient has rhabdomyolysis? We got to make sure that we're flushing them with fluids because myoglobin is nephrotoxic. And if you allow this to continue, if he's dehydrated, he's in trouble. He can get renal failure. So you got to make sure that you're hydrating those patients with rhabdomyolysis. Okay, now we don't have a CK on here, but if we did have a CK, we would see that it's elevated. But you should know rhabdomyolysis whenever you see a patient who has risk factors, they were on cocaine or something like that, they had a crush injury, they had a seizure, and then you see large blood, but no red blood cells to back it up. That's myoglobinuria. That's something we see all the time in rhabdomyolysis. Okay? So there you go. If we were to order a creatine kinase, it would certainly be elevated, but that's kind of a dead giveaway. Myoglobin, like I said, nephrotoxic, so bad thing. Now, why don't we need to give him phosphenitoin? When would we give phosphenitoin to a patient who's just had a seizure? Status epilepticus. Okay, so if he was seizing for 7 minutes, we would not only give benzodiazepines to abort the seizure, but then we would also load him up with an anti-epileptic. Furosemide, that's not going to help here. Okay, furosemide not only is it a diuretic, but it would worsen his volume status, increase the concentration of myoglobin in the urine, and that would be a bad thing. Sodium bicarb infusion doesn't work. Alkalinizing the urine would decrease cast formation, but that's not the problem here. We need to get the myoglobin out. DC methylphenidate, not the cause. Although methylphenidate and stimulants, especially things like cocaine, can raise your risk of rhabdomyolysis. That is not the cause here. Discontinuing the methylphenidate would not address the underlying problem. So it is C. Okay, question 8. A 49-year-old man presents to the clinic complaining of fatigue and lower extremity swelling for the past 3 months. The patient has a past medical history of hypertension and HIV infection. He had a runny nose and a cough last week. He was diagnosed with HIV infection 6 months ago and was started on appropriate medications. Medications include lisinopril, tenofovir, emtricitabine, and bictegravir. He doesn't drink alcohol, smoke, or use recreational drugs. Vitals are as shown. Physical exam is remarkable for bilateral pitting edema of the lower extremities. Labs are as shown. We'll take a look at that in a little bit. UA reveals moderate proteinuria and glucosuria. Renal biopsy shows cytoplasmic vacuolization of the proximal convoluted tubules. The proximal tubular cells show a loss of brush border, basement membrane denudation, and intracytoplasmic eosinophilic inclusions. There is no apparent inflammatory infiltration of the interstitium, and the glomeruli appear normal. Which of the following is the most likely diagnosis? Let's look at our labs. So here's what you got. Okay, let's go ahead and look at our answer choices. A, post-infectious glomerulonephritis. B, allergic interstitial nephritis. C, tenofovir-induced nephrotoxicity. D, HIV-associated nephropathy. Or E, hypertensive nephrosclerosis. Okay, let's go to our answer. Here's your labs again. Tenofovir-induced nephrotoxicity. Okay, so basically what this boils down to is you need to know about what these drugs do. Okay, first place you need to look, of course, is your drugs, because drugs can certainly impair your renal function. As a matter of fact, you look, okay, lisinopril, that doesn't harm the kidneys. Tenofovir, can that harm the kidneys? You bet. Tenofovir is toxic to proximal tubular cells, and that's exactly what we see here. Emtricitabine doesn't really do anything. Bictegravir doesn't really do anything. Tenofovir is an NRTI. NRTIs interfere with cellular activity. And it can have toxic effects, though, on normal cells. So we think of NRTIs, reverse transcriptase inhibitor. We like to think these are very, very safe drugs because they block an enzyme that we don't really have in our cells. But in fact, there are problems here. Tenofovir is eliminated by the proximal tubular cells, and very high concentrations can interfere with mitochondrial DNA synthesis, and that's going to lead to damage, cell death, and ultimately, if the proximal tubules aren't working, you're losing phosphate, you're losing protein, you're losing glucose, you're losing tons of things. And why are you losing it? You're losing it because all those things are reabsorbed in the proximal convoluted tubule. You reabsorb a lot of things in the proximal convoluted tubule. The rest of the nephron, sure, you're reabsorbing sodium and potassium and chloride and water. But in the proximal convoluted tubules, that's where you're reabsorbing that phosphate and the proteins and the sugars that you don't want to get rid of. If you're getting rid of all those things, that's telling you you've got a problem in the proximal convoluted tubules. What's another name for this, where the proximal tubule isn't working, you're just spilling out a ton of stuff in your filtrate? Fanconi syndrome. Not to be confused with Fanconi anemia, which is completely different. Same guy naming it, but a completely different disorder. Okay, so what this basically expects you to know is how the biopsy will look. And so once you see proximal tubules, you should immediately be thinking of tenofovir because that's what it affects, and pretty much that and that alone. It's not going to affect the interstitium. It's not going to affect the glomerulus. It's purely proximal convoluted tubules. Okay, post-infectious glomerulonephritis. We would expect to see that after a strep infection. Did this guy have strep? Runny nose and a cough. We don't see anything about a fever. We don't see anything about exudates. He wasn't on antibiotics. And remember your Centaur criteria? Is a cough consistent with strep throat? No. If you've got a patient with a sore throat and a cough, it's probably an upper respiratory tract viral infection. Allergic interstitial nephritis. Oh, and by the way, post-infectious, that's going to cause glomerulonephritis, proliferative glomerulonephritis. And you can look up a picture of that if you want. You'd also see cola-colored urine, which we don't see here either. Allergic interstitial nephritis. So here, this is kind of an allergic reaction. You'd expect to see a fever, rash, eosinophilia. We don't hear anything about that here. On urinalysis, you'd expect to see sterile pyuria, hematuria, and casts, white blood cell casts. What about HIV-associated nephropathy? Kind of same thing here, hematuria, hypertension, edema, like we did see in this patient. But the difference here is that this also is going to show changes in the glomerulus. Here, what are you going to see? Focal segmental glomerulosclerosis. So you've got your glomerulus here. You can kind of, you got all those little capillaries coming in and all that. Kind of looks like this. You can see like that. So we would expect with focal segmental to see, oh, I don't have purple. Okay, I only have blue, but it will look purple on your, if you look at a picture of it. You'd see these little nodules, these sclerotic nodules all over the place. And they're focal and they're segmental. That's what you'd see in HIV-associated nephropathy. Focal segmental glomerulosclerosis can come from a lot of things. Change back to black here, if I can. There we go. Okay, hypertensive glomerulosclerosis, what we expect to see there. So this patient doesn't have a history consistent with that. They have a history of hypertension, but we don't see anything about it being uncontrolled. Okay, hypertensive nephrosclerosis is from long-standing, poorly controlled hypertension. But the biopsy would be different. We would see changes in the arterioles. We would see intimal thickening. We would see luminal narrowing. And we would also see glomerulosclerosis here. You could also see a renal interstitial fibrosis because you're not getting as much blood flow, or even atrophy. Okay? Let's see if I can go on. All right. So here you can see the denudation here, basement membrane there. You can see this is normal here. And what you can see is you're just sloughing off. And there you can see those cytoplasmic inclusions. So again, you can see it here. Looks completely off. All right, question 9 and 10 come as a couple. So we'll go through 9 and then we'll go on to 10 and then we'll come back. All right, question 9. A 50-year-old woman presents to the clinic complaining of progressive weakness for the past 2 months. She says she has difficulty going up the stairs and doing her usual landscaping work. She says, I'm not sore, I just can't move around like I used to. She denies muscle pain, joint pain, diplopia, dyspnea, dysphagia, abdominal pain, and intolerance to heat or cold. Past medical history includes type 2 diabetes, diagnosed at age 27, and is well controlled medically. Medications include metformin and atorvastatin. She doesn't drink alcohol, smoke, or use recreational drugs. Vitals are within normal limits. Physical exam is remarkable for reduced strength of the deltoids and hip flexors bilaterally. Deep tendon reflexes are intact. There is some tenderness on palpation of the small joints of her hands, but no swelling or erythema. The remainder of the exam is unremarkable. Labs are as shown. Which of the following is the most likely diagnosis in this patient? Let's look at our labs. Okay, so here's your labs. Okay, let's look at our answer choices. A, polymyositis. B, adverse drug effect. C, hypothyroid myopathy. D, polymyalgia rheumatica. Or E, myasthenia gravis. So here's our labs again. And we're going to move on to question 10. Okay, the patient's diagnosis is confirmed and she started appropriate therapy. She returns for follow-up 3 months later and says that while her weakness has improved, she now gets short of breath even when walking up one flight of stairs. She also complains of an occasional cough during this time. Vitals are within normal limits. Physical exam is remarkable for bibasilar crackles. Muscle strength is normal. Neck veins flat. The remainder of the physical exam is unremarkable. BMP and CBC are within normal limits. Chest x-ray is normal. Which of the following is the best next step in the management of this patient? A, high-resolution chest CT. B, bronchoscopy. C, transthoracic echo. D, serum B-type natriuretic peptide, or BNP. Or E, pulmonary function tests. Okay, let's go to our answer for 9. So it's polymyositis. All right, what's the first thing we need to do here? So you've got a patient who's got progressive weakness for a significant period of time. You need to be thinking of myopathies, okay? She's got weakness and a little bit of pain on palpation, but this is mostly a weakness thing. So we think of myopathy. The very first thing you need to do when you've got a patient with weakness, with muscle tenderness, you need to get a creatine kinase and you need to get a sed rate. Always, always, always. Okay, the creatine kinase will tell you if you've got muscle inflammation. The sed rate will tell you if you have inflammation, period. Okay, creatine kinase is going to be released when you have muscle breakdown. If you've got inflammation, you'll have a little bit of breakdown. What do we see in a patient who's got polymyositis or dermatomyositis? Both are elevated. Remember that polymyositis and dermatomyositis exist on the same continuum. What you have is infiltration either of CD8 cells in polymyositis or B cells in dermatomyositis, and you get that inflammation, you get muscle damage. And so that's going to cause your elevated creatine kinase, and because this is inflammatory, because you've got these inflammatory cells, you're going to have an elevated sed rate too. This is really the only one that does this. The only myositis that you're going to have an elevated sed rate, elevated creatine kinase. And I got a table for you in a little bit that's going to help you out. Remember what our markers are for polymyositis and dermatomyositis. Do you remember? Anti-what? There's 2 of them. Anti-what? Anti-Jo1 and anti-Me Too. Okay, Jo1 and Me Too. All right, so adverse drug effect. She is on what? Metformin and atorvastatin. Can statins cause myopathy? You bet. But it would not cause an elevated sed rate. That is not inflammatory. It can cause muscle damage because remember, statins can impact your cellular metabolism, and the muscles are particularly affected. Remember, statins can give you a rhabdomyolysis, but it is not inflammatory. Hypothyroid myopathy, same thing, not inflammatory. Polymyalgia rheumatica, is that inflammatory? We just talked about it. Yes, it is. Polymyalgia rheumatica is inflammatory, doesn't cause muscle breakdown. She's also not quite in that age range yet. 50, yeah, we can start to see it, but usually it's going to be 60s, 70s, and beyond. Myasthenia gravis, small muscles. She's got hip flexors, deltoids. You wouldn't see that in myasthenia gravis. Okay, so it's polymyositis. And the answer to question 10 is pulmonary function tests. What we know with polymyositis and dermatomyositis is that you have an increased risk of lung disease. And so we always need to start with pulmonary function tests. You can get a chest x-ray is good too. That's fine. But you got to get pulmonary function tests. And the pulmonary function tests are done because patients with polymyositis and dermatomyositis have an increased risk of interstitial lung disease. And so we want to check that. This patient's coming in with bibasilar crackles, a cough, short of breath. Those all point to possible restrictive lung disease. And so we need to check out for that. So the answer is E. High resolution chest CT is something we would do if the PFTs came back with a restrictive pattern, so low volumes and all that, but premature here. Bronchoscopy will tell you nothing. Transthoracic echo, this is not cardiovascular in origin. The neck veins are flat. There's no fluid on the lungs. There's no swelling, nothing like that. BNP, same thing. This is not a congestive heart failure. So the answer is E. So here is your differential for myopathy. We've talked about these things. We hit two of them in this video, PMR and polymyositis. You can see the difference with PMR. It is not muscle breakdown. It's just widespread inflammation. Responds rapidly to glucocorticoids. Inflammatory myopathies, here you do have inflammation and it is in the muscle, so you are going to have an elevated creatine kinase. All right. So fibromyalgia versus polymyositis versus polymyalgia rheumatica. You should know the difference. Very important. These are all pain syndromes. So well, polymyositis isn't, it's weakness, but these often get confused. Okay, so very, very important. Fibromyalgia, most important thing there, tends to be women, tend to have psychiatric comorbidities. These trigger points are important. They come up all the time. But the most important thing, normal lab studies. Polymyositis, painless weakness. But they can occasionally have some pain. It's not perfect. But on your exam, look for painless weakness. Elevated inflammatory markers, elevated CK. You see both of those in the context of weakness, boom, polymyositis. If they got a rash, that heliotrope rash, dermatomyositis. Biopsy for polymyositis is an endomysial infiltrate. For dermatomyositis, it's a what? Parafascicular infiltrate. Okay. Polymyalgia rheumatica, we talked about that. A little bit more systemic science. Patients tend to be older. They may have scalp tiredness, jaw claudication, visual changes. If that's the case, that's temporal arteritis. You need to get a biopsy, put them on high-dose corticosteroids right away. You're also going to see elevated inflammatory markers, but you'll see a normal CK. There's no destruction of the muscle here. This improves rapidly with steroids. Low dose if it's PMR only. If you have concomitant temporal arteritis, then it's going to be high-dose corticosteroids.